For those of you with us, I am proud to introduce the next presenter, Nayab Sultan, who is an OHS professional since, let's just say, several decades ago, because I care not to age anyone. They were first trained as a safety and public protection inspector before being further trained by the UN as a factories inspector, a registered UN expert in occupational safety with a career that spans over 35 years and 60 nations, including many in the global south, as well as the UK and Canada being home. I'm welcomed to introduce our next presenter and hope that they have a very riveting presentation for us coming up. Since I'm not the technical one, I will now pass it on.
So Nayab, you should be able to speak.
Okay, good morning. Can you hear me? What about now?
Try now.
Can you hear me now?
Yeah.
Okay, great. And are you able to see my slides?
Yeah.
Okay, wonderful. Thank you very much. Thank you for the compliment of not aging me, which is highly appreciated. I apologize I couldn't join you, my colleagues there today in person. I've been experiencing quite a serious bout of bronchitis, so you'll have to bear with me if I cough or splutter, but I'll do my level best to try and keep as much focus as I can. So this particular presentation is about the work that I did about 2 years ago in Eswatini, and I wanted to just give you a very quick overview of the study that we had. And I did share the original study with BCIT with Bobby, who asked me to present today. So with all due respect to all my peers, I will make a start, and I'd like to share by first sharing a video.
Do I use? They told me that I've got silicosis. Most of them, they are too weak to travel. They are too ill to actually stand up and then also do the claims.
I've got a problem with my children. There's no enough money for schooling. I'm suffering. He died. He was suffering TB.
We have been advocating that the services must be decentralized, must be brought too close to the communities. things are promising.
Okay. Thank you very much. Can you still hear me, guys? I hope you can. All right. So as you saw from that short video, it was produced by the World Bank with various organizations. This is not all of the organizations, oddly enough, but the main organization that we're referring to is the one in the middle called SAMA, which is the Southern African Miners Association. SAMA as an organization was set up several years ago to work in the advocacy space for miners, mine workers, and their families. The reason why I chose this particular topic was that I've been involved in occupational health and safety for many years, as our colleague alluded to earlier on, but I've actually been looking at the issue of silicosis for probably since the early 1990s, perhaps mid-1990s, when I first met an individual who had been suffering from an occupational lung disease and was not aware what it was. And then when I started speaking to them, we realized that it was probably as a result of the fact that he worked in a road crew blasting the rock face up in the Himalayas. So it gave me a sense of purpose to try and really look at trying to deal with the preventative side. So it was for that reason I came into the field of looking at researching silicosis and other occupational lung diseases. So let's see, I'm sorry, I just have a quick message. Okay, thank you. I apologize for that. Right, okay. So we've seen the video and I shared with you the various partners involved. So you're probably wondering who I am. So as mentioned, I've been in occupational health and safety for many years. I'm a specialist and I'm an advisor with the United Nations. But I did want to mention specifically the work that I do in sub-Saharan Africa. The Southern African Miners Association until recently had nobody in the field of occupational health and safety or occupational medicine. During COVID, I was approached and asked if I would be able to advise and assist, and I've continued with my work in a pro bono capacity while I work full-time in industry. Through the work that we've been doing with SAMA, we engaged with the University of British Columbia. I helped assist with as a co-investigator and a co-sponsor to get grant funding for about 600,000 Canadian dollars, which is fantastic. The idea was to use novel technology, AI technology, for the early detection of TB and silicosis. And there is particular software that is used that is applied to devices like the X-ray machines that can pick up on TB and silicosis. The reason why TB is also mentioned is because those who are exposed to high levels of silica dust, or respirable crystalline silica, or the multiple polymorphs of silica dust, silicon dioxide, can also be predisposed to developing pulmonary tuberculosis. Because of my study as well, I got the opportunity to advise the Ministry of Health, and in particular looking at strengthening the National Cancer Registry for Eswatini, which is the former name for Swaziland, to look at developing and bolstering the list dealing with occupational, work-related and environmental carcinogens. The reason why that came up, and I'll mention it a little bit later, was that in the study we found that only 3% of cancers in Eswatini are attributed towards work-related causes. And then I also have my own part-time consultancy, which allows me to do some of this work pro bono. So as I mentioned, SAMA was set up many years ago by a number of individuals working in the mining sector space. They realized that there was a lot of injustices relating to mine workers, particularly former mine workers, and the vulnerabilities that they had. The particular cohort of mine workers in Eswatini was considered to be particularly vulnerable. Swaziland at the time, or Eswatini as it's called now, also has the reputation of having the world's highest HIV and AIDS prevalence rate. And that's relevant to this topic because there is a strong connection with the various comorbidities, which I'll mention a little bit later. So really, SAMA's principal role was to try and deal with justice in various forms, and my role is more on the health diplomacy and health equity aspects of supporting 10 countries and then various national associations within SAMA. So the affiliates include the very top one, which is the one that we did this study with, which is the Swaziland Migrant Mineworkers Association. They were set up, again, they're an NGO, a non-governmental organization that works with ex-mine workers in Swaziland or in Eswatini, of which there are about 38,000 ex-miners there. And then we also work with all of the various other organizations and associations as well. So where is Eswatini? I mentioned the name Swaziland a few times. That was the old name, colonial name. It is in sub-Saharan Africa, right at the very bottom tip. So it's the southeastern part of Southern Africa, and it's landlocked. It also happens to be the country which had the oldest mines in the world, which date back many tens of thousands of years. As a nation, it's a small country. It also has a small population, approximately 1.3 million post-COVID. According to the World Bank, it was 1.23. I won't go into too much details in terms of its geopolitical situation. So the reason why Eswatini fared highly in this particular study was that it's actually not just Eswatini, it goes back to the region. So since the 1800s, there was a lot of work done in the mining sector in sub-Saharan Africa. A lot of the countries were under colonial rule, as many of the older folk, those pre-1990s will remember, we had apartheid in South Africa. So what happened in the past was the black workers were seen as a cheap labor pool to draw from the various countries in Southern Africa. They went to South Africa to work in the mines. There are various types of mines, diamonds and copper and various other minerals, but the gold mines are the most lucrative. Typically what happened was that people would migrate across the continent to Southern Africa, to South Africa in particular, to work in these mines. Those particular mines were considered to be quite difficult environments to work in. There was a lot of hardship and poverty, and diseases were rampant, and it was a lot of it was due to pre-existing health issues that people had, but there were also very poor living and working conditions. It wasn't uncommon for people to maybe about 20 people shacked up in the same room, sleeping in bunks on top of one another. One would come out and another one would jump in because they were working in shift rotations. So it was a breeding ground for illnesses and diseases, particularly things like tuberculosis amongst the cohort, but also because, as I mentioned, there's a strong correlation between silica exposure and tuberculosis, and particular form known as silicotuberculosis. Typically what would happen is these mine workers would work for about 18 months. They would come in relatively healthy, I'd say relatively healthy, loosely, but because of the very difficult and arduous conditions, quite often they were retrenched. So that basically means that if there was occupational health services, the occupational physicians in particular would just sign them off, say, okay, this person has failed a medical, and they would just be booted out of the country. And quite often what would happen is they would go back to their native country because South Africa would have evicted them, and then they would go back and be burdened with this particular disease that nobody would tell them. because the occupational physicians at the time were in collusion, unfortunately. There was a lot of documentation to support that there was a lot of corruption in the occupational medical space at that time. So what we know is that silicosis is considered to be the world's oldest occupational lung disease. Mining is considered to be particularly high around the world. Any industry really where there is exposure to high levels of silicon dioxide or quartz is where you're going to be particularly vulnerable. So you have construction and various manufacturing sectors, mining, tunneling, quarrying, etc., are also very high in that. Worldwide, the official statistics estimate roughly about 44,000 deaths from silicosis, but that is actually only very specifically silicosis as a disease. I'll explain why I mentioned that a little bit later as well. But there's an estimate that because so many people are exposed to high levels of respirable crystalline silica dust, that the numbers will probably be in the tens of millions worldwide. And just to give you a comparison, even here in Canada, we have an estimated 380,000 workers who are exposed to high levels of respirable crystalline silica in the working environment. And that's a statistic from CareX Canada. The reason why we feel that the rates are probably higher in developing countries for various factors. I alluded to existing health status, but also because legislative mechanisms in various countries are also relatively weak that don't protect workers and society as a whole from this particular issue. So in the mining sector, I know I'm in a group of industrial hygienists, so I'm not going to delve too much, but you have very high temperatures. A lot of these mines are very deep. They'll go down several kilometers. And as you approach the Earth's core, the temperatures can exponentially rise. 60, 65 degrees Celsius is not uncommon. Saturation levels in terms of relative humidity can also be approaching 100% in a lot of these mines because they're using water at the face to try to suppress some of the dust, but also to try and provide some cooling effect. This was obviously, as technology and information has been gathered over the years by research, and hygienists have been actively involved, these environments are not as arduous as they used to be in the past, but there are still informal sector mine workers, which we refer to as zama-zamas in that part, and also we have artisanal small-scale miners as well. So their conditions may still be as what was in the past. Inadequate ventilation, air movement is an issue as well. Ionizing radiation, particularly from radon, has been shown to be an issue of concern. I mentioned various contaminants, poor ergonomic postures. There seems to be still a lot of manual work in terms of physical force being applied, like jackhammers and various mechanical aids, and that because of the tight environment, the constrictions, not only does it cause heat stress, but also it has a higher rate of musculoskeletal disorders, particularly upper and lower limbs. Noise and vibration, again, things like noise-induced hearing loss, whole body vibration syndrome, Raynaud's syndrome, which is white finger, is quite common, and then pressure waves from blasting, and then the presence of other physical hazards like heavy equipment moving around and claustrophobia and other things are all sort of combining factors which make it quite a scary environment to be in. I've been in several mines over the years, and I have to say that I dread going down in those particular mines in Southern Africa because they're so deep and they're so because we know the history as well. Once you know the history behind it, you tend to be quite nervous about that environment. So what did we find from the study? It was basically over a period of 3 years, we looked at if we could determine what the prevalence rate of silicosis was. That was really the crux of it. I realized very earlier on that it was probably going to be quite challenging. There was very little information in terms of quantitative data or mixed methods data research undertaken. So we had to take a different tact. I did a literature review of nearly 1,000 references, which kept me up for a lot of nights during that period. But what I would say was that it was quite evident early on from the onset that it was probably not going to be possible to determine the prevalence rate of silicosis or other silica-induced diseases, particularly because a lot of the mine workers were also exposed to legacy exposures, not only in the mines there, but also in the mining sector in Eswatini as well. Eswatini has actually, I'll say it still has, the oldest mine in the world, and they also have asbestos mines, but they have not been worked in for the last 2 decades or so. Another thing that we found that black workers were racially more predisposed to silicosis and other lung diseases. There's a whole raft of research behind that. It's not just an assumption, it's based on fact. We also realized that the living and environmental conditions, particularly with dwellings being close by and child labor and women also being happening, but also people trying to make a living from stuff that minerals coming out of the ground. And so what we found was that you would find shacks or huts close to mines, and quite often a lady would have a baby or a child strapped to their back, or they were working with them to break rocks to see if they could find gold or anything of that nature. So it was a little bit more complicated than that, but there was that issue also. And then also we found that animals were also being exposed. That was both domesticated and non-domesticated animals. There is a fairly large body of research that shows that silicosis or other forms of illness associated with the exposure to respirable crystalline silica can also affect animals. Here in BC, WorkSafe BC produced some guidelines for horse trainers, but we know that silicosis happens in beavers, in various other creatures, including camels and things of that nature. We don't have any camels that I know of in Canada, but it does exist amongst other animals, mammalians included. And we also realized that a lot of the information and data that we had was coming from outdated sources. We found that there was very little in terms of legislative protection. The only reference that we found in terms of silicosis was backtracking one step to pneumoconiosis, which is defined as a occupational lung disease under the workers' compensation legislation. So I'm just going to quickly skim through some of these points. What we realized also that, as I mentioned, the health status was an issue with many of the workers, because a lot of these folk saw mining as a rite of passage to as they would grow up. There was a lot of people who worked particularly or lived in the southern part of Eswatini who saw working in the South African gold mines as a natural cycle. Their brothers, their uncles, their fathers, their grandfathers had also in many cases followed the same path. So it was something that they did as a family in terms of occupation. There are opportunities for work, but Eswatini, also like many other nations in the global south, does have a high unemployment rate. So you would find that people would go relatively young, relatively healthy, and once they were exposed, they were then more vulnerable to communicable and non-communicable diseases, tropical diseases, and some of these new emerging diseases, like as heat-induced kidney diseases, were also starting to show their face. In sub-Saharan Africa, we're aware of the triple major health burden that exists with HIV, tuberculosis, and malaria. In Eswatini, we found that actually silicosis or silica-induced diseases was likely to be the fourth quadruple burden, and I'll explain why a little bit later. Government agencies had very little control in terms of dealing with ILO Convention 161, which relates to occupational health services. Health surveillance was very loosely done in some organizations. Large mining corporations do have well-established workers' health and safety and well-being programs, but not everybody works in those particular companies. There's several operations around. And as I mentioned, a lot of those ex-miners in particular had legacy exposures before, rules of governance started to get more and more stringent over the years. There's very little known about silica as a hazard and silicosis or silica-induced diseases. And also there was very little in terms of actual lung health, which was quite surprising. There was only one reference to pneumoconiosis, as I mentioned, in outdated legislation. Also, what we found was that, and this is probably a universal issue actually, what has happened over the years is typically we think, okay, we're exposed to silica dust and therefore we're going to get silicosis. Well, actually, that's not necessarily the case. What we found from research from around the world, and there was a particular study done in Washington State where they did a study with over 280 construction workers who had been exposed to high levels of silica beyond the occupational exposure limits for various periods of time. But what they found was that those who displayed silicotic conditions there was only one person. There was only one person who indicated typical silicotic conditions. That was an issue. But what happened was most people displayed symptoms of COPD and emphysema. And so the study concluded that rather than assuming that silica exposure leads to silicosis automatically, is that perhaps we need to be looking at other indicators, other initial indicators like COPD, chronic obstructive pulmonary disorder, emphysema, other types of pneumoconiosis, and then those exposed to, say, coal with progressive massive fibrosis, etc. So that was also something that we thought, well, this might be an indicator that we need to take into account as well. Some of the silica-induced diseases also are not really respiratory in nature. You have illnesses and diseases such as autoimmune conditions like lupus, rheumatoid arthritis, kidney dysfunction. And yes, of course, you do have things like lung cancer, but there are a variety of other diseases in between that either have very strong evidence or suggestive evidence that exposure to silica is likely to be a factor behind those as well. We also had to look into the issue of other types of hazards that these workers may be exposed to. As you would imagine, in some parts of sub-Saharan Africa, biomass fuels are still used in huts and in dwellings of various types. That itself leads to indoor air quality in these small spaces, and a condition known as lung hut pneumoconiosis became evident that that was something that needed to be looked at as well. And then there's also hypersensitivity pneumonitis, which is also intrinsic allergic alveolitis, which typically tends to happen from antigens from hay and things of that nature, animal feeds, for those who may remember their occupational history days. So what we've realized that the co-infections and comorbidity issues were interlinking. Everything wasn't very clear-cut, but what we did know was that because of this triple burden that exists in sub-Saharan Africa, there was more information that existed about silica exposure or mine workers' health and HIV and AIDS, and then tuberculosis and malaria as well, which are all influencing factors. So what we found was that at the time, the rates of tuberculosis was 733 out of 100,000 people. In mine workers, it was 5,000. So you can see that that was a huge jump, that mine workers were significantly more vulnerable and exposed to factors that could lead to pulmonary tuberculosis. I say pulmonary tuberculosis because there are several forms of TB as well. You can get TB of the stomach, you can get TB of the bone, you can get TB of the skin as well. But we looked only at pulmonary tuberculosis, i.e. the one that we considered to be the typical one. As I also mentioned a little bit earlier, Eswatini and also one of the neighboring countries, Lesotho, the mountain kingdom of Lesotho, also has a long history of sending its menfolk to the mines. Both nations have a very high HIV and AIDS prevalence rate. As you can see, there was a little bit of a difference in terms of the statistics. Nationally, 29% of the population, if you just think about that for a second, 29,000 of the population of 1.3 million, that's a huge number, which is why it's considered to be one of the highest prevalence rates. But when you look at it from mine workers as well, it's still 20%. Now, of course, there's a lot of those mine workers will be tagged in the national statistics, so we weren't able to break those apart. But typically in the past, why there were higher numbers of mine workers who had HIV and AIDS was that, I'm talking very generally, so please excuse me, a lot of the young folk would get some money, there would be a windfall with money, they would go out, they didn't have partners, and you typically around these big industries, a lot of sex workers and a lot of informal sectors set themselves up. And so particularly during the 90s, 2000s and early 2000s, the rate of HIV and AIDS really skyrocketed. A lot of them, if they did have family members, they would go back home to their own native countries, and unfortunately they would then pass on this infection. At that time as well, the diagnosis was not as great. There was a social taboo around these things, so that the rates had shot up and before they started coming back down with a lot of effort from around the world, particularly with agencies like UNAIDS actively involved in this part of the world. I'd mentioned that the concern that we identified in terms of silicosis or silica-induced diseases probably would add a fourth or quadruple health burden to Eswatini. The reason why I mention this is that from studies undertaken in neighboring countries, we can see that the prevalence rate amongst oscillatory migrant mine workers, artisanal small-scale miners, those who are involved in Zama related activities, which are individuals who try it on, which is basically what that word translates to. The prevalence rate was anywhere between 32% to well over 50%. We tried to do a comparative study with other neighboring nations who worked in similar environments, similar numbers. Lesotho was the closest one, which had a prevalence rate well over 40. And also Zimbabwe as well, which is higher up in the continent. So what we did was we did a little bit of math. Based on the information that we had, we could only put a scale in. But even if you go on, say, 50% as the upper level of what it's likely to be, what we felt was that with a population of 1.3 million, we kind of broke it down. We thought, okay, currently there's about 100,000 miners who work in the country who are working in sub-Saharan Africa. 38,000 of those are ex-miners, which means that there's 138,000 of 1.3. If you do the math, that's 10% of the population. If you then look at the fact that you have this particular cohort who are exposed to very high levels of respirable crystalline silica and other air contaminants and other hazards, if you go on the basis of anywhere between 30% to 50%, that's still 5% of the population. That's a huge number of people within your nation who potentially have this life-threatening, non-treatable disease. And why it was particularly of an area of concern, and which is why I decided to do the study initially, was tuberculosis under an X-ray looks very similar to silicosis. There are various mechanisms that we have in place, for instance, in North America and various other countries, where a radiographer would have to go and do a training. They classed as NIOSH B readers. The diagnosis required for tuberculosis is significantly faster, it's easier, and also TB is treatable, whereas silicosis quite often looks very similar to tuberculosis. And so quite often TB cases were being misdiagnosed as tuberculosis. And so what was happening was that these poor folk who were already immunologically compromised or already quite sick from one of the various forms of silicosis that exist were suddenly given these very aggressive medicines for tuberculosis. And it would then accelerate their health. Sorry, let me rephrase that. It would accelerate the decline of their health to the point that it would actually cause them to die much faster than they perhaps should have died. And that was a great travesty that I'm sure most will agree shouldn't occur, particularly in this day and age, but it does. That's the reality. That's why we did the study recently. That's why we were trying to determine why there was what was the prevalence rate of silicosis and silica-induced diseases. And we weren't able to determine it categorically, only suggestively from some other countries within the region. Also, another factor that makes it problematic is sometimes both TB and silicosis and silicotuberculosis, which is the link bridge between the two, can be asymptomatic, which means that you don't really display symptoms. You don't actually have manifestation of an illness. So you could have it and you don't realize you have it. It's basically what that means. So you can find that your health is getting worse. Perhaps there might be a little bit of an indication. You might have a little bit of a cough. You might find that you get a little bit winded more often, but real aggressive forms of manifestation is not always available. And the reason why I also mentioned why this was considered important was I then reached out to the National Institute of Occupational Health in South Africa. They have a compensation system for those who worked in the South African mines after some big legal battles that occurred with these former mining corporations. A lot of them were British in nature. A huge case law was won, money was set aside, but the issue of trying to give compensation or workers' compensation to deceased mine workers is nonsensical. It doesn't add any value. Of course, you can pass it on to surviving family members, but the reality is that there was a lot more information available in terms of autopsy reports. Again, there was a little bit of corruption initially during the earlier years. Occupational physicians were not declaring silicosis. It could have been also because of this misdiagnosis issue, but there was some evidence to show that there was deliberate denial of conditions. It would often be put down to, oh, you smoke, or you have bad habits, etc. But when it came to the autopsies, it was quite clear. You could see that there was evidence of silicotic conditions or real damage to the lungs. When I asked about receiving access to these, it was granted. Unfortunately, even in the cases where you could prove categorically that a person probably had died as a result of silicosis or complications as a result of silicosis, it was very difficult to backtrack and find records. So that particular group was always considered to be a key and vulnerable population for that reason. We do have access to these things now. There is a lot of work that's going on, and I'll come to those slides shortly. But the issue of mine workers and ex-mine workers and their dependents are all considered to be particularly vulnerable in that part of the world. And I would suggest that that's probably a universal truth around the world as well. And I also believe we were talking to the AIH President earlier he alluded to the geopolitical position in the US. A lot of the funding that has been received over the years in that part of the world came from US sources and also other sources as well. Unfortunately, we're already seeing a knock-on effect in our ability to provide support for this particular cohort. So we are, and I would say on an individual level, I'm still very concerned about the issue of occupational lung diseases, particularly amongst mine workers and former mine workers. The issues of silica dust, it's much easier to deal with. There's a lot of information that exists. However, particularly in small scale mining, the controls are just not there. Interventions, they may be effective or they may not be effective depending on what options they go for. But the reality is that in these resource restrained economies, that people are always going to put their stomach over their health in terms of basic survival. We also note that there is a lot of issues relating to child labor, and now also female mine workers are also coming into the picture. That's for DEI reasons, and it's good in terms of female workers, but child labor obviously is something that is not something that we support. But there is evidence of that. Typically what had happened in the past, and I spoke about legacy exposures, was that when the menfolk would typically go down south to the gold mines in South Africa or the mines in South Africa in general, the womenfolk, because their menfolk had taught them the principles of mining, they would then quite often go to the asbestos mines that existed in Eswatini. And they, because of childcare issues, their children would be strapped to their back or the child would assist them. So we also have a lot of those, as I mentioned earlier, legacy exposures from the past as well. It's getting less and less in terms of child labor because of the ILO, the International Labour Organization, working more closely with governments to avoid that. So trying to fast forward, I'm cognizant of my time. We're looking at using AI technology. CAD technology, computer-aided detection, is now becoming a real thing. But we also realize that there's a lot of misinformation that exists out there as well. There's a lot of local traditional beliefs that exist. Typically what had happened, and I know that this was something that was an eye-opener for our colleagues at the BCIT talk, was that quite often a lot of the mine workers would go back home unwell. They walked in health, they left healthy, they came back pretty poorly. The traditional belief systems in some of these smaller villages and smaller towns was that it was black magic, it was juju. And so these people would be ostracized, or they believed that they had this terrible disease that was highly contagious. They didn't know it was TB or silicosis. They would assume that it was just some illness. Quite often they thought it was HIV or AIDS. And so the family would shun them. They would ostracize them. They would be put in an outhouse or in a little hut. And because they were sick and because the income stream had suddenly dwindled away, quite often these individuals will be denied basic medical care. They were denied basic medicines if medicines existed, or therapy in the case of silicosis. So we realized that there was a lot more to this, so we needed to look at it from a social scientist perspective as well. So that's something that we want to look into. We're also looking at working strongly with the national tripartite partners, which typically is under like the National Occupational Health and Safety Committee, that typically is set up by the Ministries of Labour, Health, employers associations, maybe the trade unions as well. We work with all of the above. We've worked with all of the above. In this particular research, we were very fortunate that the king of Eswatini, King Mswati III, he is a very strong ally of the mine workers, the ex-mine workers. and he has lent his support to this research that we did, but also to encourage future research to try and help his subjects. We're also looking at trying to use early detection and point of use technology. When I was doing my doctorate, I was initially trying to look at using biomarkers, or looking at things like, if you remember the PCR tests with COVID, it's just like a pregnancy test kit, as you know. We were looking at trying to work with various medical tech companies to see if we could look for various biomarkers. A biomarker is something that shows up in the body as a result of exposure to something. So if you inhale something, it doesn't necessarily always come back out as exhaled. You may not always detect it in exhalation. It may show up in your urine or in your blood or in your hair or something of that nature. So we were trying to see if we could develop technology. It's not the most efficient at this moment in time, but there are a few promising tools out there, things that might be used in the future, like CC16, Claricell 16, or Club Cell 16, and ILS, which is, I think it's a protein. So we are talking to and reviewing research from around the world in this area as well. We're also encouraging looking at various social determinants to health, to try and really look at all of the factors that lead to the decline of physical health, but mental health, psychosocial health as well. Health, as we know, is not just the absence of disease, but is also delves into other aspects, and that is the UN and the WHO, the World Health Organization's definition as well. Not verbatim, but that's basically what they say. It's mental, physical, psychosocial health, not just the absence of disease. And also we're trying to see if we can work with the mining corporations in particular, or those involved in manufacturing, to see if we can encourage them to have some corporate and social responsibility initiatives, and see if we can encourage them to embrace the SDG goals of the United Nations. These are the development goals, and there are several that exist which are relevant to mine workers, and I have a little screenshot of that a little bit later. So as I mentioned, working with industry, we, in the absence of strong, robust regulations within Eswatini and other countries, we're trying to see if we can encourage them to work towards embracing these ILO standards, these codes of practice that exist. ILO stands for International Labour Organization, which is part of the United Nations. I alluded to us doing some work with a couple of companies, organizations. There's a particular piece of software called CAD for silicosis. There's also CAD for TB as well. And we've been working with the organization to see if we can use the technology in the field. However, we have a couple of challenges there. In sub-Saharan Africa, we have a phenomenon known as load shedding, where electricity is cut off on a regular basis because the infrastructure is not geared up to be able to generate enough electricity. Also, a lot of the technology that exists is quite old and outdated. This is new technology, and so the expectation is that this technology should be able to talk to the old technology, and that just doesn't always synchronize as well. So, and also there is a lot of these individuals tend to go to their villages where their homesteads are. The reality is that the level of healthcare cover that exists there will be negligible. If there are healthcare workers that exist, they will be also oscillatory in nature. They'll be visiting, they'll go. They don't necessarily have the tools and equipment, or perhaps even the level of knowledge needed to be able to determine that there could be an issue with cause and effect in terms of what did you do as a job and what are your symptoms, and perhaps bridge the two together. Other things like spirometry is easier to come across. Occupational history as well is another form of the diagnosis chain that exists, as well as x-rays. But as I mentioned, the x-rays can be ineffective, or they can be misinterpreted. The beauty with this particular technology is that if you plug it in, it reads the X-ray. I'll just go back to this one. It will then tell you, oh, there is an abnormality forming. It will then score it, and it will tell you in terms of percentage whether there is sufficient statistical evidence to demonstrate that that could be a respiratory disease of a particular type, like TB, like silicosis or silicotuberculosis. Problem with that also at the same time is because this is also new in the field, they don't have enough samples in the background. The algorithm isn't as robust. You know, they would have done research on, say, animals and things of that nature, perhaps in Europe where there's better controls. But as I mentioned earlier on, there is a predisposition amongst black workers and others as well. So we're working with them in order to be able to see if we can get enough sample size done so it can help bolster the software to make it more effective and efficient for use right across the region. Even if it's just the software just says, hey, there is something that is worthy of attention, that's good. It's at least it gives you a little bit of an amber light to say this one you might want to look at further. I also mentioned that working with the governments, again, with legislation, a lot of the countries in sub-Saharan Africa, in particular Eswatini, they need to make a little bit more effort in terms of compliance with international standards. One of the good things with a lot of countries in sub-Saharan Africa is commercial companies have embraced ISO 45001, which is good. That is the Occupational Health and Safety Management System standard. But as a nation, a lot of these conventions and recommendations are still to be ratified. And that's something that we want to work with these countries with as well. If we can demonstrate to them that, hey, statistics shows or research shows that there is a genuine issue that warrants your attention, then we would hopefully be able to produce a white paper or produce a campaign which encourages the key stakeholders to start expediting those findings into policy. I mentioned the SDG goals. Here, I apologize, it's very small, but this is just an indication of some of the health-related SDG goals that exist. I've put in there maternal mortality, newborn and child health as well. It's because we have ladies working in the mines as well. Sexual and reproductive health, we've spoken about the fact that there is a strong correlation with those working in the mines, and HIV and AIDS prevalence, even though nationally it's gone down, it still is a problem in some of the other nations as well. So all of these things in combination would act as important points of reference, particularly if you look at the social determinants of health, which is looking at non-traditional sources of exposure and ill health as well. So we're working with various organizations. UBC is one of our partners. I'm affiliated to them. I'm not a member of the faculty, but as the person who is the co-applicant, the funding has been released to allow us to work with companies like Delft Imaging and Cure AI. As you can see from the image, that's a great example of something that Delft Technology has produced. It's basically an X-ray pack, which healthcare workers or radiographers can take out into rural locations, into villages, into far-flung locations, and take X-rays at the point where the person is residing. A lot of the problems that we had in Eswatini was that although occupational health service centers were set up with some funding from the Global Fund, the countries were not able to source enough funds to maintain those. It's a loss. It's a great loss for us because we had X-rays there, we had spirometry there, we had the capacity to do audiometric testing there, we had various facilities, we had laboratory capabilities where blood could be drawn to check for malaria, etc. So unfortunately, they only survived for about 2 years. COVID was really the death blow for not only the 2 centres that existed in Eswatini, but also in many of the other nations as well. University of Cape Town, University of Waterford in Johannesburg are working closely with us, and University of Birmingham in the UK, where I'm a research fellow as well. And then we're open to collaboration with your good selves, your subject matter experts, your future captains of industry as well, like the students there. So we're open to working with people, working with organizations, working with skilled and talented individuals. Perhaps you want to go out and, strengthen your skills in terms of learning how to do certain things. We may be able to facilitate that. We may not be able to afford to pay, but we would definitely be open to discussions along that line. And even in my case, I work full-time in industry as a corporate HSC manager. But for my own research recently, I realized that with the funding stopped with UN AIDS, it clearly was going to have a knock-on effect with all of the other projects that we have. And so we set up a GoFundMe page. It's available online. You can take a screenshot of that. All donations are graciously accepted, and all of the money will be used to further the cause of doing research in the field. There's a lot to be done. There's a lot of goodwill out there, but the funds are a little bit scarce. Thank you very much. You can find information on both SAMA as an organization and SWAMIWA, which is the Swaziland Migrant Mineworkers Association, on my website, and that is my email. I hope you found that of interest, and I will now see if we have time to take any questions. Do we have any questions?
Thank you so much, Nayab. If anyone has any questions, whether that's online or in the audience, you can raise your hand and we'll have a student come around. Or on the online, you can just type your questions into the chat.
Thank you so very much for your presentation. It's incredibly sobering to consider that we've known how to control exposures to silica for a very long time, and we certainly don't do a great job in places where there are more funds and regulatory systems in place. And so I'm wondering about the folks that are going around with those portable X-ray packs, what kind of training they receive and how much the packs cost.
Yes, so the packs are produced and they're manufactured by Delft Imaging, who are based out in the Netherlands. As part of the service that they provide, they get funding from various global agencies, such as TIMS, it's TB in the mining sector, the Africa Union NEPAD project, Global Fund, USAID obviously was one of those where money would filter down. So the training was provided as part of that service to the countries. In most cases, it was radiographers or those who worked in radiological space who had some awareness on how to do these x-rays. They wouldn't necessarily always do the diagnosis in the field. They would take the information back and probably give it to somebody who was trained as a NIOSH B reader or a pneumologist or some description. Cost-wise, I'm not entirely sure. We've been very fortunate that they've offered those to us because they see the value of the work that we're doing. Unfortunately, I'm sure that there's a lot of technology, there's a lot of novel technology that's being developed, of course, but it's not always affordable for organizations like these miners associations. It's only if a project scope has been developed with them that they would then be entitled to that. So we do have approximately 10 countries that we work with in sub-Saharan Africa, everybody from Tanzania downwards. There are a couple of countries that are not on that list at the moment, like Angola, or the Seychelles or Mauritius. So we kind of restricted ourselves more to English-speaking countries or where English is widely spoken, but we do speak and we do work with those in Mozambique as well, who are predominantly Portuguese speakers. Funds again is the problem. We're just running short of them, and the problem is it'll just carry on getting worse, I think, with this current global crisis with funding restrictions.
My name is Paul. I want to say thank you for this project that you are doing, Nayab. And I would also like to give an advice from a social point. A number of countries where this project is going on, the reason why workers keep going back to those mines is because they don't have another source of livelihood. And it is important for you to get the approval of the local authorities. And do not be surprised that those who run the mines might actually be the local authorities. So it's always good to have the conversation with them and provide alternative for these workers, because if they don't have alternatives, they would go back. And that would really not make the project work out. I really love this project, and I would love to see it be successful and help a lot of workers against being exposed to silica. It is also important to set up a training for them and education regularly. We know all these miners can't leave the job, but a good form of education and regular checkup would be a good way to approach this. Thank you.
Indeed, thank you very much. Yes, you know, in the mandate that I have, I'm responsible for 2 million mine workers. It's a very big mandate. It's a lot of serious responsibility. You're absolutely right. A lot of the mine workers will go back to doing mining activities because perhaps they haven't done anything else. A lot of them, if they do go back to their rural communities, they're exposed to other respiratory hazards. I alluded to lung hut from biofuels. They may also have environmental exposure with global warming. Obviously, there is now an issue of droughts occurring in many parts of the world. Soil itself can also be a form of amorphous silica dust. And that also is known to cause, it doesn't cause silicosis as far as we know, but it is known to cause fibrosis, i.e. scarring of the lung. And it can then lead to, again, health decline for those who may have already been pre-exposed to silica. So it's a perpetual cycle. We are working with Cure AI to look at doing more field-based work, to give us the details, give us statistics, to also help early detection with those who have been identified with issues. But also we're working with Delft as well. They're the ones who have the backpacks. We're working with them on health education and health promotion. And the idea is to curtail the issue of misinformation, but also to look at then another program with them on health education for workers as well. So there is work happening in the background, but it's just a little bit slower than I'd like to see it happen.
Again, I want to echo Paul in terms of my appreciation for your project. So my question is actually a follow-up to Paul, in that I hope that over the last so many years that there has been some improvement in terms of education, control measures, exposure monitoring for these workers. If you don't mind, if you can touch briefly on what improvements has been achieved in terms of legislation also and all these things to protect these workers.
Sure. So yes, there have been improvements, particularly in the established mines. The larger corporations do have good or relatively good mechanisms in place for education training, the health surveillance, etc. They may also have exit medicals as well. Biological monitoring, biological effect monitoring would be a normal part of their health surveillance program in some of these corporations. So on the larger scale, yes, there's good stuff. The problem is that not everybody works in those particular organizations which are large scale. Also, as Paul alluded to, if there's poverty involved, you're going to go back to what you're familiar with. And so quite often we have this phenomena of zama-zamas, which is a Zulu word which means to try it on. They will then work in old disused mines, and they'll go in, and quite often they'll be gone for, this is no exaggeration, they will go for maybe 2 to 3 weeks in a disused mine. And they will eat there, sleep there, they will go through, you know, with cave-ins. You hear about a lot of mining accidents that occur. There has been some education to deal with zama-zamas, to discourage them from doing that. But poverty is a strong motivator. If you look at the fact that, you know, you may have dependents at home, you're not getting compensation or you're not earning a wage, people do anything, you know, within reason, of course. But, you know, I know if I was in their situation, I would probably do the same. You know, it doesn't matter how educated we are, bills don't stop. And the reality is, if you have loved ones depending on you, you're going to do what it's going to take to support them. So legislation is changing. There is some legislation that came around, and it's been good in terms of dealing with the child labor aspects. That was something that was quite forcefully dealt with by the United Nations, particularly through the ILO. But when it comes to adult workers, there is little. It really depends. Some countries have better mechanisms in place than others, South Africa being one of those. Even Zimbabwe is really upping its game through the work of one particular professor who we work with closely, Professor Moyo. But when you start going down into countries like Malawi, like Lesotho, like Eswatini, even Mozambique, although it's a big country, it has a lot of mineral wealth. That wealth doesn't always transpose downwards. It doesn't manifest in form of health education campaigns or training for mine workers, nothing. And as hygienists, there's very little control as well. Very, very seldom would you ever see a hygienist in that environment, in the informal side of things. There have been some grant funds that were released a couple of years ago, and they did it in Zimbabwe with artisanal small-scale miners. That's how they were able to get some data in terms of exposures and things of that nature. And also in South Africa, there's a good industrial hygiene set up there, but that's not the case in countries like Eswatini.
Sorry, I know we've got a couple questions left, but just to keep us on track, I'm just going to end it here, unfortunately. But thank you so much, Nayab, for sharing your research with us on such an important topic. And we've got a small token of appreciation that'll be coming to you in the mail, so please keep your eye out for that. Thank you, Nayab.
Thank you very much, and best of luck with the rest of your meeting. Thank you for the invite.